Hi, good afternoon, everybody. Thanks for joining our Facebook Live. Just to introduce myself, I'm Dr. Garry Ho. I'm one of the sports medicine physicians here at OrthoVirginia out of the Fairfax and Fair Oaks office in the north. Thanks for joining us today. And I've got a great opportunity with our team here at OV to talk a little bit about entrapment neuropathies. And so what we'll talk a little bit about is what are entrapment neuropathies? When do we think about them when we see patients in the clinic? How do we make the diagnosis, and how do we figure out what flavor or what kind of problem our patients have? And then we'll go over some basic approaches when it comes to how we treat and approach these problems to help patients achieve their healthcare goals. And then hopefully have some time for some Q&A and some discussion, which I'm really looking forward to. Next slide, please. So what are we talking about? Entrapment neuropathies is sort of the umbrella term for a host of different nerve problems. These problems exist when nerves are pinched, crowded, snagged, or restricted. So some of those terms may sound familiar. You know, pinched and crowded means that the nerves don't have as much room. And then the snagged, restricted, I'll explain to you in a little bit more with another video in a moment, okay? Entrapment neuropathies has other names as well. You'll hear other terms like compression neuropathies or nerve compression or pinched nerves. And this is, again, a wastebasket term for multiple other flavors of nerve conditions. And this can happen in different scenarios. So you can see here in this slide pictures that depict a few of these. On the left side, you can see our classic carpal tunnel syndrome. And what happens there is that there is a space in the wrist that's formed by the bones in the wrist, as well as a ligament that goes over those bones. That's called the carpal tunnel. It's a tunnel through which the median nerve travels as it goes from the forearm to the hand. And that nerve can get crowded because there's lots of things in that tunnel besides the median nerve. There's tendons and vessels and other things. And so as you can imagine, if that space gets a little crowded, the nerve can get irritated because it's crowded, all right? And that can cause a whole host of different chemical changes that make the nerve hurt or feel tingling and not feel good. In the middle of the slide here, you can see another scenario where you have the same nerve happens to be the median nerve, traversing the elbow. And as you can see, normally the nerve travels between two slips of muscle that we call the pronator teres. And in this scenario, there's nothing necessarily wrong with the muscle itself, but perhaps the muscles get enlarged. I see this a lot in my weightlifters, people who work out a lot. And they get, muscle hypertrophy. These muscles get big. That's what they're going for. But those muscles getting big can sometimes crowd nerves and can cause the nerve to get irritated. So this would be another example of a scenario where you can have an entrapment neuropathy or a compression neuropathy, but due to not a space, but just muscles that are overly enlarged. And then on the right side, you can see in the upper right-hand corner picture here, a scenario where there's a kind of compression that happens on the nerve from an outside influence, an influence from outside the body. So in this scenario, we've got the ulnar nerve going into the hand as it traverses the wrist. And that puts the hand in just a position that is primed to getting irritated in people who ride bikes, perhaps a particular handlebar, a design, a bike rider who's either putting a lot of their weight on their hands or they're riding over rough terrain. So there's a lot of vibration coming up from the bike through the handlebars. And that can actually irritate the nerve, the ulnar nerve right there. And that can cause a type of compression or entrapment neuropathy. And then the nerves can get crowded, pinched, or restricted from other disease processes. So in the lower right-hand side of the slide here, the picture, you can see what's called a ganglion cyst. This is most likely what we call a paralabral cyst in the shoulder. That's a picture of the back of the shoulder there. And that cyst has grown and actually crowded and pinched the nerve nearby called the suprascapular nerve, and that can cause problems there. So you can see that entrapment neuropathies can occur for a variety of different reasons and in a number of different scenarios. And that's what we're going to be talking about today. Next slide. So how does this happen? And I'm not going to bore you with too much detail, but it's fair to say that it's fairly complex and very nuanced. And when we even look at just the anatomy, let alone the chemical side of it, but the anatomy of a peripheral nerve, you can see nerves aren't just as simple as a metal wire. They're more like a kind of a high-tech data wire that has multiple other wires in them to transmit a whole host of complex information to and from different parts of our body. So our nerves are very complex, and it's really an organ in and of itself. And because you have a lot of moving parts, that reflects how much the nerve actually does for us. But that also sets up a structure that is prone to things going wrong and injury. So when we have things that pinch the nerve, some irritation or chemical irritations to the nerve itself can get irritated and painful. And by the way, the nerve has nerves supply the nerve. So it's a lot of different structures that can get irritated and can cause symptoms. One thing I'll call your attention to, especially in the upper right-hand corner, which you see, is that there are several different parts of the nerve that you could see could slide past each other. And we're going to talk a little bit more about that in a moment. So in this next slide, we have a video which shows a median nerve. This is a video of the median nerve at the elbow as the patient is moving their wrist up and down. So if we can replay that over and over again until we're done with this slide. But what this shows is, I just mentioned that the nerve has multiple different parts that slide past each other. What's also important is how its relationship is to the other structures around it. You see, the nerves outside of our spine, and even to some degree in our spine, are part of our body. And in this case, we're talking about nerves in our limbs, in our arms and our legs. And because we move our arms and our legs, it makes sense for most patients to visualize their muscles and tendons moving. But we often forget about the fact that our nerves move too. And as we move our arms and legs, the nerve glides and slides between tissue planes. And that's normal. That's part of the normal biomechanics of the nerve. And a nerve that's able to glide and slide freely is a happy nerve. A nerve that is not allowed to glide and slide freely is often unhappy. So you can imagine, certainly if you pinch the nerve, it doesn't glide as easily. That makes sense. If you crowd the nerve, it makes sense. But let's say you don't have anything physically pinching the nerve, but the surface of the nerve is just inflamed. Well, when you get neuritis or inflammation in the nerve, one of the things that can happen is that inflammation can make the nerve sticky. And when it gets sticky, it doesn't slide as easily, and it creates a little friction there, which further irritates the nerve, and the nerve will make more inflammatory hormones, and then the nerve gets more angry and painful. And so part of our treatments, as we'll talk about in a moment, both non-procedure as well as procedure, is to reestablish this gliding action of the nerve, to free the nerve of not just stuff that's pinching it or crowding it, but to allow the nerve to move freely so it establishes its normal biomechanical activity. So we'll talk a little bit more about that in a moment. So when do we think about nerves? And so certainly patients come in presenting with a variety of symptoms that can be pretty classic for nerve pain. So obviously nerves can hurt and you can get pain. The classic type of pain people will feel with nerves is a burning, cold, burning, hot and cold sort of feeling, numbness, tingling, shooting type pain, electrical feeling type of pain. And that's fairly typical of nerve pain. However, it's not always the case because there's many different types of nerves. Sometimes people can have nerve pain that isn't classic for that numbness, tingling, burning sort of sensation. Sometimes you can just get achy pain, and sometimes that can be a little problematic for both the patient and the provider because it can actually make things a little muddy when it comes to trying to figure this out. But there are plenty of other clues that can help us distinguish nerve problems from other problems. Nerve issues often radiate or shoot or travel along the course of the nerve anatomically, and can sometimes involve areas, meaning causing symptoms in areas far away from where the pinching or the crowding is happening, because the nerve transmits information to and from that area, and that's the reason why. So in this lower right-hand picture, for example, let's say you were to get a nerve entrapment of the common peroneal nerve in the knee. You might get symptoms down at the ankle because the nerve transmits information to and from that area. So that radiation can be a clue. And so the location and pattern of symptoms can give us clues about nerve issues. In the world of sports medicine, when we're talking about people moving and trying to perform, sometimes nerves don't get entrapped unless things start to swell a little bit. And so with exercise activity, muscles swell, And sometimes they don't get symptoms until that happens. When that happens, sometimes a very vague symptom can occur, and that's exertional fatigue, meaning that the muscles that you use get tired out more easily than before. That can happen either due to nerve or blood vessel issues. And so that's another scenario where we might think about nerve problem. And then finally, nerves don't just transmit sensory information or sensation, they also supply muscles, and they help muscles move around. And so really severe nerve problems can actually cause muscle dysfunction and cause weakness, and sometimes in more severe cases, a shrinkage of the muscle bulk. So what do we start doing once we start to suspect an entrapment neuropathy? In addition to conducting an interview with the patient to get all that previous information we talked about, we'll also do a physical exam, a detailed physical exam. We may start off by looking at biomechanical alignments and things like that. And some of that we can get from interviewing the patient as well. And then there are a series of physical exam maneuvers that we can do to kind of test and can look for clues as to whether or not this is an entrapment neuropathy. We won't go too far into it, but it includes things like pressing on the nerve, tapping on the nerve, and other positions that put the body in a situation where we're pinching the nerve and observing the patient's response to that. And then what else can we do other than our physical exam? And there's a whole series of different diagnostic tests that we can do. In the office, we frequently get x-rays, other tests such as CT and bone scans, and other vascular studies. Basically, diagnostic tests on blood vessels. Most of what I've just mentioned is mainly aimed at trying to rule out other causes. As you can notice from those symptoms I talked about, nerve symptoms overlap quite a bit with other types of problems. And in order to make a good diagnosis, sometimes we have to rule out the other potential candidates for what's causing the patient's problem. So we often order tests to rule those things out. If we're talking about tests that actually give us more valuable direct information, we might look at MRIs and ultrasounds. And so you can see here an ultrasound on the right, easily see abnormalities in a nerve, especially since with ultrasound, we can actually compare left and right side. So if we're lucky and the patient has a symptomatic side and a non-symptomatic side, we can compare and contrast and look for clues there. So you can see on that right side of the screen, we have on the top side, a normal looking peroneal nerve, and on the bottom side, you can see that nerve looks thicker and actually has developed a focal area of swelling that is called a neuroma and sometimes a fusiform neuritis. So I'm a big ultrasound guy, and I use it every day in my clinic for the majority of my patients, and it provides some pretty valuable clues. So if you look at the picture in the upper left-hand corner, that's a cross-section image of the median nerve versus the picture in the middle. So this is like looking, if you cut the nerve like a tree trunk and you're looking right down at the stump. And so you can see a big difference there. Where if you look at the picture in the middle, top middle, that's a picture of the median nerve. You can compare that to the picture on the right. It's swollen, it's darker, it's less distinct, okay? On the bottom left-hand side, you can see a nerve long ways. And you can see that nerve is very clearly like a striated or striped appearance. And in the middle bottom and in the lower right-hand side of the slide, you can see what a median nerve might look like when it's not happy, when it's swollen, edematous, and inflamed. Another test that we'll sometimes do, and this is where I often partner up with some of our other colleagues, both in OrthoVirginia and in the community, but it comes to looking for other clues to test the nerve. So we've talked about ultrasound, MRIs. That's a way to look at a picture of a nerve, but it's like looking at what the plumbing or the wiring looks like. We can actually test the electrical activity of the nerve as well. And this is analogous to testing the electrical circuit in the wiring of your house. And that's what we call electrodiagnostic studies, nerve conduction studies, and electromyography, or EMG for short. And this is another test that we'll sometimes do as well. So treatment. And so what do we do when it comes to treatment? And it's very situational dependent. So we want to individualize our treatment strategy for the patient, the type of nerve problem, and their particular scenario. So it all depends on the type of nerve, which nerve, what type of entrapment neuropathy, and what the patient needs to get back to doing, their physical demands. So we do want to individualize our treatment. We often use a combination of different approaches. So I often suggest definitely want to, these are what I call the R's of treating entrapment neuropathies. We want to rest the area. We want to limit the amount of insult to the nerve. So if the person is doing a daily activity that's chronically pinching a nerve, we might either use splinting or other activity modification to relieve the nerve, at least temporarily, of those insults. We might give them medications that can cut down inflammation, perhaps medications that can decrease how sprightly the nerve can fire, because nerves that are irritated often fire way too easily. So there are medications we can use to help manage their symptoms and their pain. Sometimes we'll use injections, like corticosteroid injections and nerve blocks that can be helpful. And then finally, rehab. And there's a whole host of rehabilitative approaches, both formal rehab with physical therapy, home exercises, nerve glide exercises that are aimed to try to reestablish that sliding of the nerve that we talked about. And then finally, traditionally, there are surgical approaches, which I'll talk about as well. And then there's non-surgical treatments, procedures, which I'll also mention, called hydrodissection. And then if everything else fails, we have started to do an OrthoVirginia peripheral nerve stimulation, which is when everything else fails, we could think about stimulating the nerve. It's an implantable electrode that can stimulate the nerve to provide relief from symptoms. So a little word about surgical treatment, and this is where we work at OrthoVirginia as a multi-specialty team. I collaborate shoulder to shoulder with my surgeons, and we have a really nice partnership. I'm a non-surgeon, but I think even for a non-surgeon, a good understanding of the surgery helps us as a team educate our patients better. So there are a series of different surgical approaches. I'm not going to get too far about it. Some of them will basically involve, again, opening in a surgery to release some of that scarring around the nerve, to allow the nerve to glide more freely, perhaps to disentrap or unentrap or take away the pinching of a nerve. Sometimes, in some cases, we'll actually move the nerve to a different place. But there's a lot of surgical approaches. And if and when patients need to consider that, we have a very pointed discussion about those options. So just a reminder here that a lot of times when we do our treatment, especially when it comes to procedures like injections and surgery, we're trying to reestablish the normal physical state of the nerve, and that includes this normal gliding. And so this is where, because of our use of ultrasound, we've had the opportunity to do some procedures that previously were only the purview of surgery, but non-surgically. And this is a procedure called hydrodissection, and we'll talk a little bit more about that in the following slide. But in this slide, I want to illustrate that what we're trying to do is reestablish this healthy gliding of the nerve. And so before we move to the next slide, I'll just talk a little bit about it. What we're doing is we're using injections to put fluid around the nerve, to open up the space around the nerve, to peel off scarring from the nerve and allow that nerve to essentially float in a ring or a channel or cylinder of fluid, to allow the nerve to float around a little bit better. Of course, the fluid gets reabsorbed over a few days, but the idea hopefully is that coupled with the hydrodissection procedure, if the patient goes back to doing nerve glide exercises, that when the fluid gets absorbed, this gliding action can be reestablished, the nerve being placed in a happier state and the symptoms being relieved. So does that work? And this slide is just to remind me to tell you that it does. It does work. There's been studies done over and over again about ultrasound-guided hydrodissection. And certainly there's no silver bullet in anything in medicine, but it has been shown to be very effective for a large number of people with peripheral nerve entrapments. And this is from a systematic review in 2021, and there have been a number of studies. Now, granted, most of the studies are done in the upper extremity, but a growing number of research is done elsewhere in the body, and we can extrapolate quite a bit as we learn more and more about these conditions. And then finally, this slide illustrates what that might look like. So on the left-hand side of the screen, you can see that median nerve. Again, this is a cross-sectional view, kind of like you're cutting the nerve like a tree trunk and looking right down at the stump. You can notice that nerve is somewhat enlarged, but it's got this flattened discoid type of shape, right? And a nerve that's completely free of any contact of its surrounding tissue often looks completely circular. So on the right side of the screen, you can see that procedure. And what I do, and this is the same patient, left and right here, I bring the needle in alongside the nerve. So you can see precision is really important when it comes to safety and effectiveness. Bring the needle right next to the nerve and inject fluid to not just deliver a medication, but to use the hydrostatic pressure from the volume of that injection to separate the nerve from its surrounding soft tissue. And that includes things that can crowd the nerve, things that can pinch the nerve, and also sometimes some scarring and what I call adhesions, the stickiness around the nerve. And you can notice that by the time we're done hydrodissecting that nerve, the nerve shape looks way more circular. And you can see in the next frame right here, look how round and circular that nerve is when we're done compared to the picture on the left here. You can see it's nice and circular. So I often tell people a round and circular nerve is a happy nerve. So to summarize, nerve entrapments are really important. They have a very wide range of different symptoms and presentations that can fool people. And it takes a skilled clinician to figure out what the actual culprit of a patient's symptoms are. And so sometimes it takes a little investigating. Sometimes it takes a little trial and error. But I think it's important to keep in mind that nerve problems often see us more than we see it. Peripheral hydrodissection is a popular procedure now. I've been doing that procedure since 2008 when it was really not that popular. Now it's pretty wildly popular among most of us orthopedic and neuromuscular proceduralists. But it requires a lot of training, time, skill, and experience, especially for the safety and also the effectiveness. There's a lot of research, which I won't get into, maybe in the Q&A, when it comes to how else we can help these nerve problems. So with that, we'll go to the finishing slide here. Thank you so much for your attention. I look forward to the Q&A and the discussion that follows.
Thank you so much. We have had a lot of questions submitted. So thank you everybody who submitted questions in advance. You are welcome to continue submitting questions in the comments here on Facebook, and we will do our best to answer as many questions as we can during the live. Our first question is just a follow-up about the hydrodissection. How long should a patient expect the positive benefits of that to last?
You know, that's a great question. Thanks for that question. I get that question every time too. It varies. There's a lot of different factors that can influence how long people get relief from hydrodissection. The type of nerve, which nerve, actually how badly the nerve is entrapped, okay? There's also metabolic conditions of the patient that need to be taken into consideration too. The healthier the patient metabolically, the more likely they are to respond too. So if somebody has unfortunately very difficult to control or poorly controlled diabetes, hypothyroidism, they are more likely to have these nerve problems to begin with. They're more likely to have more severe disease, and they're also more likely to have a more stubborn case. So when it comes to the positive benefit and the relief that you get from hydrodissection, all of those things can heavily influence how long that can be. It can be anywhere from lasting for a couple of weeks to a few days to actually fixing the problem outright and everywhere in between. And so it can be very, very variable. My usual practice is actually to start off with hydrodissecting the nerve and observing the symptoms over the course of a month. And basically I often educate patients that they might still be feeling great after a month, which would be awesome. They might not. And then that tells us a little bit about how their problem responds to the treatment. And based on their response, how long they get relief, what kind of relief, we can use that as a surrogate to figure out biologically what's happening at the nerve and then decide whether we need to repeat it. Do we need to change how we do it the second time and so forth? So the short answer is it's complex and it's variable. The medium-sized answer is that it can be anywhere from a couple of weeks to months to even a permanent fix.
Thank you. The neuropathy that you were talking about today, is that the same type of neuropathy that people get after they've had chemotherapy or other similar treatments?
No, it's not. And so what we're focusing on today is what we call entrapment neuropathies, where nerves get physically insulted in a way, by pinching, crowding, or snagging from around the nerve or even outside the body. So what we're talking about often with chemotherapy and other systemic neuropathies is a little different. That's really more about the medical and the biological health of the nerves themselves. And so those are a bit of a different conditions and often less likely to respond to local treatment. However, a lot of people with diseased nerves from a systemic cause or a whole body cause, like chemotherapy or from metabolic problems, they are also more likely to develop entrapment neuropathies on top of it. So sometimes people will come in and say, yes, I have peripheral neuropathy, but this one area has gotten worse aside from the other areas that I had peripheral neuropathy from my chemo years ago. It could be that they have an entrapment neuropathy on top of it. So sometimes we'll treat that. There are also a small number of case reports where people will have a systemic neuropathy like one from chemo, and they'll get hydrodissection done, and they do get some relief, although not a significant amount and certainly not curative, but it can play a role in some of their treatment too. But no, this is a little bit of a different problem.
Thank you. Can you please explain the difference between spine and non-spine neuropathies?
Yeah, absolutely. And it really comes down to location. If you think of these nerves as like different parts of a tree, you can think of the trunk of the tree as the spinal cord, okay? And then you have the branches that come right off of it. We'll call them maybe the divisions that come off of them, okay? And then you have the smaller branches that go all the way out to the leaves, okay? So if you think of nerve entrapments in the spine, we're looking at really entrapments around the trunk and when the branches first leave the trunk. Anything outside of that is what we call peripheral nerve. Okay, so what we're focusing on mostly today was entrapment neuropathies outside of that the trunk and when the branches first leave. So that's the difference, is that it's a different location. It's also different because just like a tree, if you have a diseased small branch, it'll maybe affect some leaves, right? Or a larger branch, it'll affect other smaller branches. But if you have something that affects the trunk of the tree or one of the larger branches that come off, it affects a larger segment of the tree. That's the same thing when it comes to talking about nerve problems in the spine versus outside the spine. Nerve problems in the spine affect a larger part of the body, so that's another difference there. Some of the treatments that we're talking about with hydrodissection, rehab, injections, and even surgery, you can actually apply, at least from a conceptual standpoint, to the spine, but the techniques are obviously very different because it's a totally different place in the body with a different anatomy. So there are things that can compare, but there are a lot of differences too.
Thank you. Do you have any examples that you could share of nerve gliding exercises or where people might be able to find them?
Yeah, there's a lot of nerve gliding exercises online. I think that some of them are more effective than others. I think with the modern era of connectiveness that comes with technology and social media, you'll be able to look for a lot of nerve glide exercises out there. Again, they're not all created equally, so I do recommend that you consult with a healthcare professional to talk about whether those exercises are good exercises, whether they are likely to help you, hurt you, etc. Certainly, I have specific exercises that I'll give for particular conditions, and also partnering with a good physical therapist often is worth its weight in gold when it comes to developing exercises that work best for an individual's nerve entrapment. But there can be some simple ones, So, for example, a median nerve exercise could include this type of motion here, okay? But I don't want to get too far into many details because there are probably 80 different ways to skin that cat. So that's one example, but your mileage may vary. And I would recommend partnering up with somebody who is experienced in these matters to help you find the best exercise for you.
Thank you. Is hydrodissection generally covered by insurance, and is it done in an office or a hospital?
That is a great question. And no, there isn't a code. So if you're talking about coverages, in our current era of getting things paid for and having health insurances, the way we often communicate with health insurance is what we do, and therefore seek reimbursement and coverage, is through codes. And fortunately, there actually is not a code for hydrodissection specifically, but there are codes for peeling off scar from a nerve, reestablishing the normal physical condition of the nerve. And you can use those codes as a surrogate with some modifiers, and coding is a whole art form in itself. And use of those codes can be variable as far as coverage from insurance companies. Here at OrthoVirginia, there are a lot of efforts underway to make that process more streamlined and more reliable and predictable. But yeah, coverage will be variable for insurance coverages for hydrodissection. That being said, the other part of the question is it done in the office, in a surgery center, in the hospital? And you can do this in an office. Anything that can be done in the office can potentially be done in a hospital or a surgical center, but you don't have to necessarily do it in a surgical center. But yeah, it can be done in any of those settings.
Thank you. Do entrapment neuropathies contribute to weakness in the limbs? For example, a weakness in the legs while climbing stairs?
It can. Typically, entrapment neuropathies of the peripheral nerve are going to be way more focused. So you'll actually have weakness with one particular muscle, or one particular muscle group, but not another one. If you have generalized weakness throughout the entire leg, that speaks to something further up the tree, like using that analogy. So now we're thinking about a nerve problem that's closer to the spine. But if we're talking about nerve entrapments a little further out in the limb, yeah, it can still cause weakness, but it'll be more of a more smaller area. So for example, using that example of walking and weakness in the legs, we might have somebody who has foot drop. So as they walk, they can't pick up their toes as much. And that would be typical. And if there's no other weakness, we would be thinking about an entrapment neuropathy in the common peroneal nerve versus, say, the entire limb is weak. Then we're thinking of something a little further up, maybe in one of the bigger nerves near the spine, near the plexus, or even by the spinal cord itself.
All right. Thank you so much, Dr. Ho. Would you like to close?
Yeah. Thanks a lot, everybody, for tuning in and joining me for my first Facebook Live with OrthoVirginia. I hope it was useful for you. If you get any questions about whether it's entrapment neuropathy or any other musculoskeletal or neuromuscular condition, we've got a great team here. I'm really excited to be here. And so come seek us out. We're happy to help. We're happy to be here. And I wish everybody a really great day.